Thank you for joining us for the February Grand Round session entitled Overview of Integrative Rehab Practice, Transformational Rehabilitation. Today's webinar has been designed for 1 AMA Category 1 and 1 CE credit towards continuing education for psychologists. Submission requires an account with the Vanderbilt Online CME Center. Instructions will be sent to all attendees following our program. We invite you to our next Ground Round session on March 22nd, featuring an outstanding panel from the Oregon Health and Science University Comprehensive Pain Center. At this time, I would like to introduce our session moderator, Dr. Yan Zhang, Associate Professor for the Department of Family and Community Medicine at Texas Tech University Health Sciences Center, and Vice Chair of the Consortium's Clinical Working Group. Yan?
Yes, thank you, Dale. Good morning, everyone, and welcome to our Consortium Clinical Group monthly Grand Round webinar. And it's my great pleasure to introduce our speaker today, Mr. Matt Erb. Matt is an integrative physical therapist, the founder of the Embody Your Mind, and a senior faculty member of the Center for Mind-Body Medicine. He received his degrees from the University of Iowa. Matt has worked extensively with the persons experiencing acute and chronic health conditions using an integrative model of care. He specialized in supporting persons experiencing chronic pain, migraine, headache, dizziness, and a vertigo, state of physical and mental health comorbidity, mind, body, and more. Matt is also very passionate about educating other healthcare professionals to integrate the science of mind-body medicine, stress, and integrative wellness into their practice approach. He is also working to expand the role of the physiotherapy in psychiatry and mental health in the United States, as well as working to support the field of yoga therapy. And Matt will share his experience with us today, and without any further ado, we'll let him to start. By the way, and at the end of his talk, we'll have Q&A sessions, so please send your questions to chat. Thank you very much. Matt, it's yours.
All right, thank you, Yan, and hello, everyone. It's great to be here. I'm very honored to have this opportunity to talk with you about the work that we're doing in this application of integrative medicine to rehabilitation medicine, to rehabilitation therapy professions. And so I just want to start right out and give you a little bit of disclosure information. I'm faculty with the Center for Mind-Body Medicine, and I have no relevant disclosures with my work with the center. I am founder of a teaching and consulting business, Embody Your Mind, and just disclosing that I do offer continuing education programs in these topics. I have not presented any promotional talks to any pharmaceutical or commercial companies in the past 12 months and will not discuss any off-label or investigational drug use. So these are learning objectives, and I put these up because it's important for CE settings, but I'll let you take a look at those. I know you have access to the slides. I don't want to use a lot of our time to go through each of those, but these are some of the topics that we're going to touch on. And so what I want to start with is just to put this slide up about moving beyond lip service. As a physical therapist, it's been about, I think probably 9 or 10 years ago, there was a special issue in Physical Therapy Journal, which is a peer-reviewed journal in my profession. And the editor-in-chief gave an editorial. It was a special journal about psychologically informed practice. And she talked about how there's a growing call for biopsychosocial models in care, particularly in relationship to our chronic pain epidemic. And she had written, this is Dr. Craik, had written Now is the time to yell about these factors, that we need to move beyond lip service. And so there's been a lot of momentum in the last 10 years that have really propelled integrative medicine to a very respectable forefront within the biopsychosocial spectrum. And so this is the premise behind the need for disseminating topics of integrative medicine to a much larger audience, and particularly within the rehabilitation profession at this time. And you'll see as we go along, I, like many people, are expanding that biopsychosocial to spiritual. Biopsychosocial spiritual practice starts now, and we'll touch base on that idea shortly, but that addition deepens the consistency of the idea of a biopsychosocial framework so that it's in alignment with many of the current constructs that define what integrative actually is. All of these things that I have listed here are topics that I think are important for the study of integrative medicine within the rehabilitation professions. So we need to be able to provide solid definitions and look a little bit at the history of how this has evolved. I'm going to talk today about mind-body medicine. I really think it's a foundation. And then what you see below that are a series of other topics that I include in the teaching that I do in this area, with sociocultural determinants of health, an integrative look at chronic pain, the need for professionals whose foundation typically has not been in psychologically informed areas to have some transdisciplinary education that allows them to, at the very least, be psychologically informed. But I advocate for taking that one step further so that it's psychologically integrated, that there's safe and relatively accessible and simple presentations of how to bring psychosocial integration into care. Supporting subjectivity, I think that much of this is about relationships. It's about the balance of the interaction between the provider and each person that comes to see them, as sort of part of the container that defines an integrative experience. And you can see some of the other subtopics there as well that can sometimes be delved into as a foundation for integrative practice. And the reason that I have this slide up, this is an interesting cartoon of finding answers to problems, and you see the masses moving to the left, simple but wrong. And then we see the few individuals going down this winding, complex path. And just a little bit of, was it Robert Frost who said that two paths diverged within the woods, and I took the one less traveled by, and that has made all the difference. So I don't want to paint that this is a negative thing. It's not deterring people away, but sometimes what's required to engage in complex and integrative thinking, we're sort of, we really like the simple solutions. We like things that fit nice and easily into a box. And we have to be comfortable with a lot more ambiguity and a willingness to be present to unpredictability when we take this integrative path. So I'm just going to start with that and put this quote up as well too. There's a shortened version of this quote, and I always like when I'm going to use a quote to go and look at the source. Where was this originally quoted, and was it modified? And sure enough, this is the full quote of that the only true voyage of discovery would not be to visit a strange land, but to possess other eyes, to behold the universe through the eyes of another, of 100 others, to behold the 100 universes that each of them beholds, that each of them is. And I think that that's also part, for me, part of the motivation, part of the spirit of an integrative model is really looking at this through this lens of just how much is unseen, that the unseen informs that which is seen. And it's easy for us to fall into wanting to make assumptions about what is causal, that A causes B, when in reality correlation doesn't imply causation, that we have to be able to look at that broad spectrum of factors that may be interacting. So when I talk about introducing rehabilitation professionals, we got a broad scope of professionals. PT, OT, speech language, voc rehab, recreational therapy. Now I'll mention that some of these, yoga therapy, art therapy, music therapy, massage therapy, may already categorized as integrative or as CAM, complementary and alternative medicine. But I want to make a point that oftentimes the public thinks that integrative, and even a lot of healthcare professionals who aren't deeply embedded in the integrative world believe that that the word integrative automatically implies that it's CAM therapies, things like reflexology or energy work. And while they can be considered, they can be included when it's person-centered, it's patient-chosen, that there's some degree of support in the literature for their utilization. I argue that integrative actually comes back to some other foundational concepts so that integrative practice can be applied irrespective of whether you're actually offering one of these modalities or therapies that falls under the label of CAM, complementary and alternative. Of all of these, the one that I want to make note of is yoga therapy. As a physical therapist who's had a lot of training in yoga and yoga therapy applications, I see that yoga therapy is from a wisdom tradition. It's sort of a psycho-spiritual technology that comes already complete as an integrative model. And so this reinventing of integrative constructs, sort of like we got overly reduced and now we're building back up, yet there's been models of healthcare that had an integrative foundation from the very start, and I see yoga therapy as one of those. So we also have all these other areas that work within the field of rehabilitation medicine, so physical medicine and other relevant physicians, rehab nurses, psychiatry and psychology professionals, and so on, all may take interest in this lens. So I want to give you this little case example. And I note that these are compilations that I put together for educational purposes, and there's no identifiers of any one specific person here, but says, I have a patient that I would like to refer to you. She's been sick for over 1.5 years and hasn't been able to eat or drink normally. 20 years old, had a neck injury. She's had extensive medical workup, including imaging and various treatment. She has a lot of pain in the neck and can't move the neck as it's frozen. Her muscles in the neck and throat bulge out and get very hard, especially when she tries to move or walk. Since February, she started having a sharp pain, like an electric shock or needle. Throat gets she needs to move or walk too. The jaw has been misplaced. She cannot eat or drink normally as it's painful and swallowing is hard, and has only been able to have very smooth pureed food for about 6 months. Before this, she was very active, busy, studious, is now in bed constantly suffering from too much pain and unable to move the neck, unable to eat or drink normally. So I invite people to ask from your current lens what possible factors could be explored to begin to assist this individual in looking at, understanding, addressing the challenge that is present within her experience. And what I'm going to do is I'm going to come back to that at the end to give a synopsis of how an integrative practice like mine might look at that. Okay. So just a reminder, we can get back to definitions and a couple of foundations, that integrative medicine is healing-oriented medicine that takes account for the whole person, including all aspects of lifestyle. And it emphasizes the therapeutic relationship between the practitioner and patient, informed by evidence, and makes use of appropriate therapies. So this is from the University of Arizona Center for Integrative Medicine. And one of the ways that I like to look at this is when I'm working with an individual, I'll talk about the idea of stress, for example. And most people think stress solely as psychological stress, but stress can come in entry points. So we can have stress from the environment. We can have chemical and nutritional stress. Yes, we can have mental and emotional stress. We have social, relational stress. We might look at, when we add in spiritual to our definition, the idea of spiritual distress, which can be a lack of purpose or meaning in one's life. And so all these different levels have to fall under consideration, and we have to look at that across a time pattern too. So how does the past in each of those levels, how might it be impacting the current health manifestation in the present as well? So it's not just present lifestyle factors, but how have past experiences impacted that? So when we look at wordsmithing, we have this integration is a noun meaning unification, amalgamation, or consolidation, the integration of parts into a whole. And both integrative and integrated are adjectives of integration. So it means being composed of or coordinated to form a whole. And I really like actually the word integral, because they all sort of tie back to this constitution of a whole together, with other parts or factors not being removable. You can't omit or remove different facets of a person's life in looking at an integrative lens. And that integrative medicine promotes an approach that recognizes and explores this construct of integral. And here we have that reminder that it may or may not include some of these complementary and alternative systems, tools, or modalities, dependent upon patient choice, if and when they're accessible and they support healing processes. So when we look at dovetailing biopsychosocial to the concept of integrative, I like to start with the classic definition of biopsychosocial, that it systematically considers biological, psychological, and social factors and their complex interactions. Now, when I have up on this slide, what's wrong with this definition? The reference that's just below is a recent editorial in, I think it's the British Journal of Medicine or British Journal of Sports Medicine. And two of the headlines, I'm just gonna pull this up on my screen. Psychosocial factors are not always mental health disorders. So I think that it's important for us to remember that not all psychosocial factors are indicative of the presence of a mental health disorder, which necessarily requires assessment and treatment by a dedicated mental health provider. The tendency for us to categorize psychosocial content in people's lives can inadvertently reinforce stigma, the whole blame-shame dynamic. And I know there's variability in this across different cultures and geographic regions, but I think it's really important that we point that out. And the second point, which really speaks to this definition and what's potentially wrong with the whole idea of biopsychosocial, is that psychosocial factors are not distinct from biological factors. So when we can form a way of thinking that understands that social actions are represented by physiological processes. Some of this is like looking at the neuroscience of social engagement and pro-social behavior. Stephen Porges' work with polyvagal theory, for example. And the same thing with psychological, the psychological realities of people's lives are represented by physiology. They're represented by brain-body patterns that need to be considered. So we tend to, by choosing these three words, biological, psychological, social, tend to split them apart already, and we've in a sense lost the idea of integrative, of seeing the interplay. And as an example of this, you see this little graph. Hopefully it's big enough for you to see, but this is from a recent paper in the journal Pain, that the need to belong, the need for autonomy, and the need for justice at individual, interpersonal, and social cultural levels are key ingredients in the biology of pain. So I have this just as an example to help people who maybe aren't familiar with looking at the lens of integrative and biopsychosocial, to see how the science now is really publishing a lot of material that helps us break down our tendency to reduce these and put these into compartments. And here we have adding spiritual. To my knowledge, this paper in 2002, Sulmazy was the first to really take Engel's original biopsychosocial model to add the word spiritual. And for me, I like to put up Joan Halifax's quote here. to reflect the importance of this, that excluding any part of the larger landscape of our lives reduces the territory of our understanding. And so I'm in support of people understanding how to at the very least ask patients, would you like your spiritual practice or your spirituality included in your care? So that there's a choice, there's an introduction to the idea. And then additionally to maybe have some basic ideas for how that can be invited in. And as I get into the mind-body medicine slides here in just a moment, I'll talk about how certain mind-body medicine skills, for example, some of the ones that we use in our work at the Center for Mind-Body Medicine, provide permission through their very design, even though they don't on the surface appear to be anything spiritual. They offer permission for people to have experiences that invite a sense of purpose or meaning or defining, or even introducing if a person's spirituality evolves from their religious practice. It gives full permission for that to come in and for people to have that as part of their healing process. So you can look at these references or some of the ones that I include as basic references on the importance. And there's a lot more. There's some very good authors publishing in the area of inclusion of spirituality in practice. The integrative approach, when we look at this says whether or not CAM is used. So that's a reminder that it may or may not be included in the integrative approach. That there's many clinical trials that repeatedly show that outcomes are improved and costs are reduced when self-care is used. So this is an image that's copyright the Center for Mind-Body Medicine from Dr. Jim Gordon's book, The New Manifesto. But self-care at the heart, and then we have therapies that require a professional, client, professional interaction that stimulate one's capacity for self-healing. I think that's a typo, it says hearing, but self-healing. So you can see musculoskeletal manipulation, group support, herbal medicine, acupuncture. And then at the outer tier, drugs and surgery then supports when needed. And so it's important to not think of either or, that it's not biomedical versus biopsychosocial or biomedical versus integrative, that there's a both and option, but it's maybe reprioritizing where we start and how we work with individuals. And that's in contrast to the emphasis of drugs and surgery, entering in to fix a problem at the center and then only placing the CAM therapies as sort of lesser than in that outer tier. And what I want to talk about is just a few areas that I think are important. So in that early slide, I said these are some of the topics that I think are important for helping rehab professionals understand integrative. Well, we've got to look at health disparity and the interaction with personal responsibility. And you see that the image is from the Robert Wood Johnson Foundation and their work on health disparity. But that personal responsibility plays a key role, but the choices that we make depend on the choices we have available to us. And it's very important that we understand that we may be asking people when we're deploying integrative practices to access things that they don't have access to, and that they may not be able to make such choices because they're not even available to them. It could be financial, accessibility, other cultural factors. So I really want to emphasize that we need to keep this in the back of our mind, because I think it's important. This is where I am for the underserved. I am for US. I am for US. Is doing work so that integrative medicine doesn't become, bourgeois medicine. That it's only accessible to individuals with capacity, financial capacity. This also, so I'm saying personal self-care is important, and we have to remember that. Self-care is important, and we also have to remember the hidden determinants to health. That the ACEs work, that generational embodiment and historical trauma, race, social conditions, local context, the presence of early life adversity in the form of adverse childhood experiences, all may be influencing developmental patterns. They may influence your allostatic load or the HPA axis. They disrupt autonomic nervous system function. and so on. And this can contribute to maladaptive coping and increasing the burden of disease up to and including early death. So for those that haven't spent a lot of time looking at ACEs, this really needs to be brought in. A colleague of mine in Tucson and partner, Dr. Nushin Ranjbar, and I have a paper that's under review now. Hopefully it'll be in publication soon, but it's looking at ACEs and trauma-informed care specifically for rehabilitation medicine, specifically because of this topic. And so look for that coming soon. We also have to look at diet and nutrition. Many of us know in integrative medicine that food as medicine is critical. It's a real substrate, it's a root within health. Yet we have all of these changes in the Western diet, the refining of grains, technology for processed sugar and vegetable oils, a dramatic change in the quality of meat, where we now have obese cows fed on corn. And I saw an article recently that a huge semi-truck of Skittles candy that had expired had tipped over on a freeway, and it was on its way to beef feedlots. And much of our public doesn't know what's going on behind the scenes. But we also have to remember that eating organic and having access to high quality food is not always accessible, because this slide then backs up to the slide on socio-cultural determinants of health. So we have all of these factors that need to be looked at, and we need to be versed in them to be able to work at an integrative level. This slide here, social, economic, cultural, ecological determinants of health, it's a busy slide, but I put it up. This is from an ecological model of diet, physical activity, and obesity. And we see this on the right-hand side, health outcomes. So we look at BMI, for example. We screen for BMI, and we look at risk factors for cardiovascular disease, diabetes, metabolic syndrome, cancers, and so on. But if we start to go back to the left, we look at the behaviors. So what are people's eating patterns? Are they sedentary or getting physical activity? Which we see that arrow going backwards, to see all of these different influences at individual levels, interpersonal, organizational, community levels, and public policy. All are going to influence this whole dynamic. And so it's showing us again, this requires forming a type of thinking, a type of contemplating when we work with each individual of what is the complexity of influences, what could possibly be addressed at this point in time. How can we convey that oftentimes these approaches are slow, they're powerful, but they're slow or slower, to be able to enter into the idea of transforming some of these levels across time for the individual to promote the capacity for well-being to emerge. So it's really a slide of complexity, but how we might look backwards, not just say, oh, you need to change your eating habit, but look at, well, what factors might be informing this, and to do so in a heuristic way, which means supporting the person's ability to come to know or discover this for themselves. So it has to be a lot of motivational interviewing and sort of a relational dialogue to begin to explore, what factors do you think are informing your eating patterns or your relationship to movement and exercise, for example. This is another one that I really think is important. So if you haven't seen this paper, I encourage you to pull it from online from a library or something. But this is from Lowe in 2017 in the Journal of Evaluation in Clinical Practice, and it's called The Dispositional Theory of Causation. And what it does, this is called a map. And you can see we have Jack here, and Jack's a lift engineer, and he's got pressure on an intensive apprenticeship in his work. He's got changes in physical activity and demand. We look at his relationships. He's got the backdrop context of a relationship breakdown, personal breakup of a long-term relationship, does not feel supported at work, and has a loss of social interaction because he's in pain. So this is an assessment of someone with chronic low back pain. We look at his beliefs. He's searching for a structural explanation for symptoms, which is very common in the public, but that's supported by the biomedical model, which causally reduces back pain to mechanical explanations and reinforces that with imaging, for example. Has a tendency towards catastrophic thinking, a tendency towards negative thinking. We look at entering into exploring his feelings, and he's frustrated, he's got high anxiety, and he's got low mood. And that's interacting, you see some of these cross arrows going up to, that's interacting with the relationships and his work. He's got a history, long-term stress. So this is not even on here, but what would his ACEs, for example, look like? What was his upbringing like? How much stress was he exposed to? He's not sleeping well, and he's got guarded movement. So this is looking at how all of these different levels may be interacting in the emergence of an experience of back pain, and that it's not just from the physical. And this is from this paper that we see these vector graphs. So the one on the left, you have that dashed line T coming down, and you have this large resultant vector which has crossed the dashed line, which means that this person is at or near a crisis. On the right-hand side of that, you've got all those factors that were on that map on the last slide, which you see here, listed out as A, B, C, D. So you got all these arrows going to the left, which means they're moving him towards crisis if they're not addressed. And you've only got one factor going to the right, which is his physical activity. He's in physical therapy and looking at addressing or changing physical activity level. If we are able to effectively interact with some of those levels, provide this individual with support to look at and address some of these other levels, we may be able to shift the entire matrix so that it's to the right of that threshold for crisis. So we see that we're either moving to the right towards a greater potential for the emergence of health and well-being, or we're moving to the left. And I like this because it helps us to see how important it is that we be equipped as rehabilitation professionals to address, for example, the presence of anxiety within our scope of practice. Through the week, I would like everyone to have access to mental health services, to psychotherapy, to psychiatry, for example. But again, we may not always be dealing with the presence of these psychosocial factors as being at the point where the person has a diagnosable condition. We also have the fact that some people divert away from accessing these because of stigma. That can be personal or cultural. And we also have places where they're not accessible to begin with. They're not covered by insurance. And so within scope of training, scope of practice, we want to be able to equip in rehabilitation professionals with integrative tools that can address anxiety within that scope. And that's where mind-body medicine becomes one of the ingredients for rehabilitation professionals to do this. Because mind-body medicine can provide people with tools, skills, and experiences that address the biological substrates of many of these things that we're talking about without necessarily having to delve deeply into specific psychological content. When I work with people on exploring ACEs, for example, I'll often say, we're just inquiring to get a little bit of a sense of things that may or may not have influenced the sensitivity, the reactivity of your some of your physiological systems. So we want to look back but not stare. The good news is we can really practice, learn and practice skills in the present that help us create shifts on, I'll say, these circuits or these pathways or these systems in the absence of a need for addressing that. And I also encourage people to get into therapeutic support from a mental health provider. In many of my cases, many of the people that I work with, if it's accessible and they're interested in it. So what is mind-body medicine, and why is it a critical starting foundation for integrative rehab practice? Well, it focuses on these relationships between emotional, mental, social, spiritual factors. It can include all of these topics. So these are various subtopics within the field that may be discussed, explored, or looked at. You can take a look at that in your slides. This is a very broad review. All of these things can emerge as a benefit or an implication of deploying mind-body medicine skills in practice. There's a couple of references there for you to look at. So you see decreased pain, improved immune function, improved mental health, decreased inflammation, for example. And we see that we're back to sort of a phenomenological approach, and that we look at the definition. This is NCAM has changed its name, but this is from 2005, regards this fundamental an approach that respects and enhances each person's capacity for self-knowledge and self-care. So we really need to be employing this model that allows people to come to know themselves better, to come to discover things on their own, and that supports sort of the narrative medicine, the lived experience. We want people to have the space to share their stories. So I put this up that self-care as a whole is an interplay of self-awareness, self-regulation, and self-expression. And that when we bring this into relationship with a patient and a provider, we're now looking at co-regulation with all of these foundations being supported. And that this can also occur in the form of a group. So it's not always possible, it's not always accessible, but small group work is increasingly being supported in the literature. Dean Ornish's work, Jim Gordon's work at the Center for Mind-Body Medicine are examples of community-based and group-centered delivery of this type of medicine. Now, this is a slide that I created to demonstrate how we split the physical and psychosocial apart, and that if we're going to be able to successfully bridge the gap between them, we need to understand what contributes to an experience of safety, nurturance, and empowerment, sort of as a foundation. So I invite people to ask themselves and ask the people they work with what might support feeling safer, more nurtured, or more empowered. Because if I don't feel safe, if I have a lack of nurturance in my experience, or I feel disempowered or victimized by what's happening, it's going to increase the likelihood that I'm out of a state of regulation, that my autonomics, for example, are in a state of imbalance, because we're hardwired for that. That's part of the stress response. And we also see this shift moving from the stool and moving to the therapist being more of a guide. This is like a health coaching, motivational interviewing approach, and it's supporting the patient as being more empowered within the backdrop of a process of mutual learning, that I'm also healing, changing, growing, and learning in relationship to the people who come to me. And that's often missed, that if I don't see that, I'm still up there on that pedestal. This is a quote from a colleague of mine, Matt Taylor, that degrees equal techniques equals outcomes equals predictability equals control. And this is the linear biomedical paradigm. You then become the fixer of the broken. And I really see this integrative construct as applied to rehab and really to medicine in general as moving away from that idea. And this is a quote from Parker Palmer that reinforces that. The human soul doesn't want to be advised or fixed or saved. It simply wants to be witnessed, to be seen, heard, and companioned exactly as it is. Now, this is sort of an ideal to put this up, and I recognize that we're dealing with healthcare systems that have very limited time. I'm fortunate to be in a profession where I can spend a full hour one-on-one with an individual. Although even in rehab therapy, there's been a move towards what I call assembly line care, where they're booking 3 and 4 people on the hour, and they have them with unsupervised technicians and aides doing, stock exercises on flow sheets. And that you can't apply an integrative construct in that type of setting. You simply can't. And it's going to require people being willing to make changes and challenge systems and come up with models. And that goes up to including the work of policy and working with payers and so on. And this integrative pain care consortium is doing that, for example, is helping reach out to make that shift. So backdrop is to please remember, this is a quote of Carl Jung to one of his mentors and one of my favorite authors, Robert Johnson, that please remember it's what you are that heals, not what you know. And I think that we go so quickly into deploying techniques, fix-it techniques in the clinic, that's often how many of the rehab therapies are seen as this technique or that technique will fix this. And we need to make a shift and apply all of this work to ourselves. This is a quote that I came across years ago that I sometimes put up in my lectures, but it's from an editorial in the American Journal of Psychiatry in 1984 by Robert Stoller, that more and more we ignore the clinical skills. So we need to support clinical skills that detect at all levels of awareness what another person is feeling. And that sensitivity to proper drug levels has pushed aside sensitivity to emotional nuance, that many professionals can't decipher the subtle and pervasive nonverbal communication that is the way humans express their interior life. I think that's also in the spirit. I don't have time to go over this in detail, but I really encourage you, this is a full text PDF link at Joan Halifax's website, upaya.org, of her model of enactive compassion. And that these are the three axes, the AA, II, and EE axis of ingredients that can be primed in an integrative practice that can promote the emergence of compassion in ourselves and others. So attentional mindfulness exercises, affective exercises, supporting people's capacity to identify what they feel and to link that to the body, intention to reduce suffering, gaining insight through psycho-spiritual wisdom into the very nature of suffering, our tendency to ride attach to the positives and resist the negatives, to bring this back to the body over and over, keeping people present in their embodiment, and that taking all of this into action. So if you haven't seen this, if you don't know about it, we don't have time to go into it in detail, but I really wanted to point you towards this paper is really important for the construct we're talking about. And also two quick quotes. The first one is, my experience with years of biofeedback training has left me with the conviction that a very large portion of the total influence on learning is biosocial in nature, testifying to the evolution of the species as a social species. Though training is often decisive for learning progress. So as a biofeedback practitioner, we look at how much that this is interacting, and this gets us into the whole world of how relationship influences placebo and nocebo, for example. And Stephen Porges, the perception of safety determines whether an individual's behavior will be pro-social or defensive, and is the turning point in the development of relationship. And that's not just relationship between the provider and the patient, but it's relationship with my experience, with my body, with other levels of relationship. All of these things that you see here, I consider to be a summary of practice shifts that I think are helpful to move towards a more integrative practice. We have to apply all of this to ourselves, including the mind-body practices. We move away from just doing to being with, sort of moving from content to context, which is that complexity. Moving from just being in the fixer role to a facilitator of emergent processes. These are processes of self-care, self-awareness, self-expression, and self-regulation. That we remember that it's that relationship, it's learning together. This is a word from Nora Bateson's Samathacy, which means mutual learning or learning together. And then the necessity of not bypassing the content of the mind. I think this is the weakest spot for rehabilitation, is that there's a lot of lip service to the need to address psychosocial factors, but there's not been adequate training in how to do that, how to work with the presence of thoughts and beliefs and emotions and expectations and prior experiences and so on. So we need to increase and step up our access to training in that area, and helping move towards a greater degree of personal responsibility and autonomy, but with acknowledgement of our interdependence. This is also a summary slide of factors that I think define integrative rehab practice. So it's fundamentally relational. It favors this phenomenological approach that explores and supports people's lived experience. It occurs within this container of relational attunement, including those principles I just had on the last slide. It also looks at the interdependence of living systems and emergent processes. I often use the example of the microbiome, that we're ecosystems within ecosystems, and when there's a disruption, that affects across levels within and between. So we really have to be versed in understanding these types of relationships. It's person-centered, puts the patient and their treatment preferences and needs at the center. It addresses this full spectrum. I mentioned all these entry points for stress: physical, emotional, mental, social, nutritional, historical, cultural, environmental. I know it's a long list, but that's complexity. Spiritual influences. And personalized strategy that will consider a full array of both biomedical and CAM disciplines, both and, to help people progress towards a greater degree of well-being. Personally, I love the World Health Organization's definition of health as a reminder that it can be a state of well-being experienced regardless of the presence or absence of a specific illness, diagnosis, or disease, so that it's possible to promote well-being within a person's experience, even within a chronic or terminal diagnosis of some kind, when we use this integrative walk in our practice. This is a slide I put together to paint a picture of how it can apply to pain, that it's not personal. Pain is universal. It affects all of us. It's a teacher and a motivator. It can become a seed for compassion, as any type of suffering can. That we need to move into a place where we have a sense of choice on how to deal with our experience of pain and improve our relationship to it. That we can lessen our avoidance or resistance of it, because that adds secondary tension. That suffering bullet point number 6 gets us into sort of the wisdom, insight traditions of how suffering is both inherent to our resistance to discomfort. I often say what we resist tends to persist. Applying or deploying specific tools like those that come from mind-body medicine, looking at the different levels. Where is change or transformation needed the most? Is it nutritional? Is it an environmental shift? Is it physical? And so on. Further exploration that this person actually had a modified ACE score of 6. This person had a history of parental divorce, parental alcoholism, bullying, abuse, early medical trauma, was in the NICU for 2 full months at birth. I think that we fail to recognize how early medical trauma influences neurodevelopment, including vagal nerve circuitry. You look at polyvagal theory, for example. Also had exposure to racism in a family context of historical religious persecution. The relevance of any of these topics had never once been explored in any capacity with any provider prior to coming to integrative rehab. Prior medical records were obtained. There were no abnormal findings in any of her testing. Personal and family history of migraine headache, and this had not been considered, that there was potential involvement of a migraine type state in her system. Had been through significant treatment approaches without any impact at all. So we started with some simple education, in this case focused on an adapted presentation of polyvagal theory, to paint the picture of dysregulation and stress and trauma states, and including through the lens of a car accident. We talked about the relevance of how ACEs, the presence of those prior experiences, could have primed her system to react more severely through a normal stress trauma response at the time of the accident, and also how over-medicalization may have contributed. This particular synopsis, and this is consistent with a number of cases I see, that this person got back to school, 50% resolution of symptoms when last seen after 4 months of therapy. So you can just get a little bit of a taste of how that looks. I do want to mention that coming soon, there is a book in development. I'll give you the authors that are contributing to it in just a minute, but this is going to define integrative medicine as applies to rehabilitation practice. This is a working title. It's not set in stone yet, but biopsychosocial spiritual practice for PT, OT, and other health professionals. Because it is targeting rehabilitation medicine, but I suspect the content of it is going to be very much appealing to that broad range of professionals mentioned earlier. These are all of the individuals that thus far are contributing. This could change, and I may add to it as well. But I will be working on editing with this with Arlene Schmid, who's a OT researcher who does a lot of work on yoga therapy applied to stroke, for example, at Colorado State. And you, if you're interested, can see some of the other contributing authors. We have people from New Zealand and the US and Israel, and trying to see if I'm missing any other countries, but a great range. We've got physicians, PT, OT, speech, nutrition, and so on, public health, psychiatry, physiatry, physical medicine. So look for that. And there'll also be some learning resources to go along with this. So there's going to be some evidence-based online CE courses, some study groups and forums for clinicians to go deeper. These are the references that I threw in there today. I know some of it was a little condensed, but I wanted to get you a good sampling. And that's all I have for you. We have a little bit of time for some questions now. So thank you. If you want to reach out to me at any time, that's actually a mistake on the email. It's just embodyyourmind@gmail.com. It's not www.embodyyourmind, just embodyyourmind@gmail.com. So I'll put this back to Dale and Yan for any questions.
Hi, Matt. Thank you so much. We do have one question. It is a two-part question. Self-care takes effort and education. How do you find your patients respond to this concept? How do you educate your patients, particularly those who are not into self-care, effectively?
Mm-hmm. This is where the motivational interviewing approach is important, as well as having some backdrop understanding of the trans-theoretical model of change. So I really respect where people are at, and I always step back and let people simply have the experience of the therapy session. I don't rush into prescriptive sort of giving prescriptions of you should be doing this and this and this. I'll frame it in the language of if there was anything that you experienced in the therapy today that felt useful, where you felt the state of mind, the state of your body. It's possible that we can help you learn to reproduce that over time. I often will say it might be useful for you to pay attention to your breathing. I don't start out and say, let's do, you should be doing 30 minutes of meditative breathing. Just say, I just want you to pay attention to how you're breathing, especially when your pain is flared up. Let's say it's a pain patient. And I'll also explore it from, tell me, where you're at. Do you have a sense of areas that you might be wanting to make some changes in your life right now around this? How motivated do you feel? May not use this exact language, but we need to be able to explore where people are at from their lens, from their perspective. And there's often a gap. So I'll encourage people to check that gap, to be able to ask, so what did you hear today? Or what's your takeaway today? So I can hear sort of how they experienced it. And oftentimes I'm shocked, like when I give education on something that is in support of self-care, and I'll say, what did you just hear me say? If you just sort of summarize back. Self-explanation is really critical to create a shift in some of those hidden determinants that inform the presence or absence of motivation. And somehow we have to connect to where that innate motivation comes from. And I don't know how many people watching might be familiar with acceptance and commitment therapy, ACT, but it's a model that helps people look at what's important to you. If people can identify first what's important in their life, they have what's called the battery exercise, for example, which has all these different areas that you may plug into for relative importance. When people can define what's important, that helps them make the bridge to why they want to make a commitment, acceptance and commitment. around their experience, and then use that as the impetus for the motivation. But I also don't ever push it. I see everything as a process, and I'm stepping back and letting that process take its own course, because it's likely to do so in some sense, regardless of my presence or not. So I just try to be with people as they are, where they are. That's my answer to that. So I know there's a second part. I went a little long.
Hi, Matt. Thank you for that. And I have another one from the audience. This is also a two-part question. And have you seen health coaches being used in IRP? And second one is, what are your thoughts about utilizing well-trained integrative health coaches?
I think the whole health coaching model is spot on to what I'm describing. And I'm an advocate for the principles of health coaching, which are rooted in many of the things I've just said. Motivational interviewing, the trans-theoretical model of change. So I see that there's a significant consistency there, I guess is how I would phrase that. I'll give you an example. The Southern Georgia and Florida VA system, VISN 8, is embarking upon a program to combine the VA's well-known health coaching model with the Center for Mind-Body Medicine small group delivery model to create a novel sort of forum for the delivery. And I see that the backdrop of that is many of the principles that I've just described here. So I'm all for the utilization of integrative health coaching. I think that I would encourage rehabilitation professionals to get training in those models or in those principles, and see how it then bridges into their core profession, their licensed healthcare practice, whether that's PT or OT or speech or whatever it is. I'm not sure, did I answer? Is there more to that question? Or I've not seen it show up, so I was trying to look to see if I saw a written version of it.
And I believe we have time for one last question. And the question is, what is the evidence of transcendental meditation versus mindful-based stress reduction for chronic pain and other chronic conditions?
I couldn't pull up the specific papers on the subsections of different types of meditation. There is a growing body of literature in general that mindfulness processes, whether it's mindfulness behavior, mindfulness or acceptance and commitment therapy, or MBSR. There are individual papers on subtopics as applied to chronic pain. It would be sort of the realm of a systematic review to try to compare the different types. As with all of the integrative and CAM sort of subsections, modalities, if you want to call them that, they all need ongoing research applied to specific populations. I might steer you towards Zeidan, Zeidan, and his lab. He's got some very interesting, or that whole lab and that whole group has some very interesting work around different facets of mindfulness, dispositional or trait mindfulness, and how that interacts with pain. In terms of the question of Pilates have any advantage over yoga therapy, well, my response to that is that yoga therapy is a complete whole person, whole being sort of model, whereas Pilates I would see more as a physical practice based on principles of core stability, core stabilization. And so I would have a hard time even comparing the two, I guess, seeing yoga therapy as a whole system of a lifestyle approach, a way to living that includes personal and interpersonal values and non-dogmatic values and ethics and many practices, whereas Pilates is more my experience of it anyway. I don't want to, if anyone out there is a Pilates expert, I'm not specialty trained in it, but I see it more as an isolated form of physical exercise.
Great, Matt. Thank you. Because of time, we have to wrap it up. And audience, thank you very much for attending this webinar. And let's give Matt a silent round of applause. I know you couldn't hear us. And thank you, everyone. I want to point you direction to the slide. You can see that's our next event. And it's going to be on March 22nd. It's going to be another great talk, and hope we'll see you there. Stay tuned with the consortium email. We will send out the notification flyer soon. Again, thank you very much, Matt, and we hope you have a wonderful day in Hawaii.
Thank you so much.
Okay.
Have a great day.
Take care. Bye-bye.
Bye-bye.